Okay, TEC providers, this is a video in place of our weekly email. I have the famous Dr. Joel Betts here. So we want to talk about three things real quick. So first, Joel, the ERs are busting at the seams. You're trying to find places to put patients. You're calling the transfer line. Things are taking forever. You hear about this surge line. What's the skinny? What is the surge line? Why is it? Where did that come from? And how do we play? How do we integrate into the surge line?
So the surge line is a statewide line that they're looking at placement, kind of collaboration between multiple systems. The theory is good, and they're bringing in people from kind of more remote towns and that kind of thing into the bigger cities as needed. The issue that we're having is that we're having some providers call the surge line in addition to or in place of the AGH transfer line. And that's where we want to steer clear of that for sure. The reason is that, as you can imagine, all the systems are essentially full right now. And so trying to push someone into the surge line doesn't really do us any good. Usually. The one exception there would be that the patient that's very sick or rapidly decompensating, someone that's intubated, something like that. But in that setting, what we still want to do is go through the normal transfer pathways. So the AGH transfer line, they may push to the Dignity line, and that is fine. But if we need to go to the surge line, that would be something that they would direct us to do. So it'd be something we want to do with their direction.
Okay, so you call the transfer line, get bumped up to Dignity, and then they may direct you, hey, this needs to be bumped to the surge line. And I believe there has to be a administrative approval to get on the surge line as well. Is that correct?
Correct. Yeah, there's got to be the administrator on call has to approve that. Now, that doesn't necessarily need to be the physician to call that. That we can have nursing or one of the facility managers do that. But yeah, we need to have administrator on call approve that call. And sometimes we may escalate as things as a patient decompensates, and so we would want to get that communication out to them. But correct, yeah. What we don't want to do is just have providers calling the surge line on their own, because it just creates a lot of background noise for the surge line. And what they're trying to do is get people placed based on severity. And we've had some calls where people are getting a surge line call for someone that's on 2 liters of oxygen or 3 liters of oxygen. That's not helping anything move along any faster. They're not going to bump anybody in line just because we're calling the surge line.
All right. And I think, too, to help kind of dissect things as we kind of look at charts. It's like, so in the MDM, it's probably wise to put in, transfer line called, date time, elevated to Dignity, date time, instructed to call surge line, date time, requesting administrative approval, date time, right? So the key thing from what I'm hearing from you and Dr. Tiffany and everybody else, it's like, standard transfer line, number 1. Number 2, it may get bumped up to the full Dignity transfer. And then from there, it may get elevated to the surge line. But trying to parallel hit just causes confusion and grief and some additional friction. So is that basically it?
That's exactly right. And what happens is it actually creates more work, because when we call the surge line, they will call back the administrator on call, say, did you approve this patient? They're only on this minimal oxygen requirement, and then it kind of gums up the system even more. So that's exactly right. And I think it's great to make sure that we're documenting this time and date, make sure we're, who we talk to, those kind of things. I know it's kind of a hassle, but unfortunately, that's kind of the world we're in right now. The other question I get on this, though, and I want to bring this up, I think this would probably be a good time, would be, what about the patient that I can't get an answer back from any transfer center? I'm intubating them, putting them on a ventilator, and I'm at, say, a outside HSED with limited resources. We've talked with Brian Tiffany. We've talked with the other FMDs at the hospitals. The answer there is going to be if we cannot get immediate placement, we're going to start working to get them from an ER to ER transfer into the hospital. The point there would be we would have additional resources, respiratory therapy, more oxygen rather than just the tanks that we've got at the HSEDs. And so that'll be the safety valve there, so we can make sure that we get people moving into the hospital and not stuck at a remote location. And I think that's everyone's greatest concern. It's not fun having someone stuck there for 20 hours on oxygen, but it's not safe to have someone there intubated for 6 or 8 or 10 hours. And I think that's everyone's greatest concern. So that's the answer there, is doc to doc. And I would encourage the doctors, remember, we all have to work together on a team here. We've got to cover each other and make sure that we're doing the best thing for the patient. If you get a call and you're at the hospital, make sure to be very lenient on your partners there to get them over and do the right thing for the patient.
Okay. Well, so that kind of brings up a segue of another thing I'd written down that I want to talk about is, the hospitals are full. I'm calling you from Texas, and our ICU here locally is at like 106% capacity, right? So trying to move patients and transfer patients is really difficult at this time. And so we're in an unusual pandemic, right? Kind of unprecedented for our generation. And so the standard of care changes a little bit, right? So the standard of care under, saturation, pandemic level things is different than, a standard flu season, so to speak. So with that, we've talked about observation in the HSEDs. And so this, I think, opens the door for all right, you've got this patient that normally would be an admit, right? They're setting 88% on 2 liters or 4 liters, or that you walk them, just not you're not having them do squats or burpees or whatever, but you walk them and they drop their sats in the mid 80s. So something, they got diabetes, so something that would be a standard admit, in your normal circumstances. This may be something that we've got an OBS protocol for COVID-19. You can put them in OBS, and then hopefully get some arrangements or resources for HOMO2, et cetera. So I think that's something that we probably can discuss. What are your thoughts on from a Phoenix standpoint, because you're kind of living it as well?
Yeah, it's one of those things where, being a line doc, when I'm on shift, I see a patient and I say, okay, I'd prefer for them to be, moving down the road, get them out of here and get them to where they're going to get definitive care. And like you say, things have really changed. We're getting these holds that are hours, if not days sometimes, especially the patients that are like you're talking about. Otherwise look okay, but hypoxic on ambulation, or they're kind of borderline, kind of right there. You're not sure if they would turn around or even if they would do okay on HOMO2. And so those, I think, are the perfect candidates for observation. And as an ER doc, we think I don't want to deal with that. I don't want to fill out all this stuff. I don't want to do this stuff. But the reality is that this stuff we're doing anyway, because they're going to be holding with us. And so if the benefit to doing the OBS is that there's a protocol in place, there's parameters in place, there are orders that are there, as opposed to trying to keep all that stuff just in your head floating around and checking out to the next doctor. Now we've got a program in place where we can put them in OBS, get the right orders going, the right treatments going, and really do the right thing for the patient. And it's a little more work up front to learn it, but once you learn the tech doc system, it's just slick and it's easy, and it's the right thing to do. Now, a lot of these patients, as we know, will turn around in a day or 24 hours or whatever, to where we could probably get them home on home oxygen, or maybe even without home oxygen. And those are good candidates to get out, because what we can do is unload the system, so to speak. So instead of having all these patients waiting for on wait lists, we can get some of them back home.
Right.
We were in that meeting yesterday, and they said that in Dignity they had over 100 patients waiting for placement just in Dignity alone.
Right.
And so it's not an issue that's going to be going away anytime soon, I don't think.
Well,
but if we get those resources in place, that's the key.
well, and I think too the thing that I find myself using OBS when I'm kind of in the pit, so to speak, is that the ones that I'm just not sure how they're going to fall, right? Like going home, gives me a little grief and heartburn, and I'd like to kind of see how they turn out. Maybe they are going to declare themselves and rapidly decompensate, and I want to know about that under my umbrella rather than hoping they go home and they remember to call 911 if they need it. And the other thing that I'm finding too is like since the whole system's constipated, I'm using OBS for a variety of things, like undifferentiated abdominal pain, or like the where I want to see how things progress or declare. So that's helpful. Okay. But you're right. It does add more work. Let's just be honest, right? You got to keep track of these patients. You got to be up on them. And when this video goes out, I'm going to attach the file. You created something to kind of help track patients that are admitted in our emergency department, so to speak.
Yeah. And the idea on that sheet is just an organized way to check out from provider to provider, because
that's a high risk time, right? Switching from the turnover is always a high risk time,
right? And it's a high risk medical legally. It's also a high risk time for patients and patient care, because we get these sign outs, and I'm as guilty as anybody else, where you're like, oh, that guy's admitted, don't worry, nothing should happen, right? Like the famous last words, and then they're like calling you to the room 5 minutes after the doc leaves shift. I hate that. I hate it. I know everyone hates that. And so the idea behind this sheet would just be like, okay, what is the basic story with this guy? When does he need meds? What meds does he need? Those kind of things. That being said, if we err on putting some of these guys in OBS, that kind of alleviates that issue, because those orders are in place. Those vital sign parameters are in place. The nurses are checking on them on a regular basis because there's orders to do so. That's why I really erred on that side, is that I want to make sure those safety measures are in place.
Okay. All right. So the final thing, and then we'll wrap this up and let you have your day, but EMTALA, right? So I think the temptation is from, maybe you're working and every room is full, your waiting room's packed, you've got holds on admits and maybe an OBS patient too, and the ambulance shows up with somebody on a gurney and you've got no place to put them. And so the temptation may be to walk out, talk to the ambulance and be like, we're happy to take care of them, but I got nothing, right? So although I can understand from a physician standpoint the logic or thought behind that, the reality is we can't do that. Like that may have good intention, but that could easily be construed as an EMTALA violation. If the patient lands on your doorstep, however they get there, walk in, fly in, come on the ambulance, you're tagged, you're it, that's it.
Yeah.
Right?
100%. Yeah, I agree. Hard stop at that point. At that point, we need an MSE. At least we need those things. Those laws are there. There's not a lot of wiggle room there. And I would just say, I don't think there's a lot of hospitals that are like, come right in. We got 10 open beds. We got nothing going on. Everybody's in the same situation. I worry that this is going to get a little bit more dicey before it gets better. And so we really need to be careful here. Because I think the temptation, at least some of these outlying centers, maybe the ones that are way out, or even just some of the ones that are in town, the HSEDs, is to say, hey, we got no room. You could run on down to this hospital. But we got to keep in mind that is an EMTALA violation every time. And,
right.
And we're going to get those reported, I think, by EMS, and we're going to really be in some trouble.
Well, and then too, you don't hear this very frequently, but as a physician, I think the fine is up to $50,000.
Right.
And I don't think that is not something that's not a malpractice claim. So that's not covered by malpractice, right? That's tag, you're it. Right.
Right. And I do think EMS is probably our hot button on this because they're paying attention to it. Because I've been hearing through the grapevine, unofficially, they're getting this at some of the other hospitals. They'll like show up or they'll call in. They'll say, hey, we don't, we got extended offload times, et cetera, et cetera. So I think they're getting it everywhere. There's some frustration there. So let's be real careful on this because I don't think they would have any hesitate reporting those in.
Yeah, and two, so sometimes it's not what you say, but how it's perceived, right? So you may be trying to tell them, hey, we've got a long offload time, but what they're hearing is you're telling me to go somewhere else. They may perceive that. So even though that's not at all what you said, like I've seen that multiple times over. So I think the safest thing to do as the line doc is be like, hey, thanks for bringing that patient. Let me get to work.
Yep. Right.
And that's it.
We'll find them a place and we'll get them seen. And that's exactly right. Yeah, because there's just no safe way to say we're full or whatever.
And I totally understand. Like if you're busting at the seams and you're stretched thin and you think this honestly is a little dangerous of an environment because we're so overtaxed. We've all been there and it's uncomfortable and none of us like it. And getting an additional ambulance patient just is kind of like, another stone on your back, but it's the life we've got. That's part of the part and parcel of the emergency medicine world. So,
yep. And I think there's something to be said for, taking a quick look at the patient. Are they stable? Is it, I mean, we've all had those ambulance transfers. They're like, seriously, you came here by ambulance? And you can give them a quick MSE and get them into triage and they can wait for a room too.
Okay.
But if it's somebody sick, that's a different situation. But what we can't do is, hey, we're pretty backed up. Sorry, we'll see if we can get you back. Wink, wink, nudge, nudge. Why don't you drive down the road? That way, we're going to run into some real trouble there.
Yeah. Okay. So last question: what's the most ridiculous ambulance transport that you got to receive?
When I was at Chandler. I had an ambulance transfer come in for a ingrown toenail.
Okay, mine was
been going on for a month.
I think mine was menstrual cramps. Although, having females in my life, sometimes that may be appropriate.
It becomes an emergency.
It can be an emergency. Yeah. I'm not going to discredit that one.
There you go.
Okay. All right. Thanks, Joel. So everybody, if you've got additional questions, reach out. Happy to kind of work through this. It's a tough time, so keep swimming, right? It'll be over.
Yep. And then I'd just say anybody in the Phoenix area, if you're stuck or don't know, give your FMD a call. If you can't get a hold of your FMD for whatever reason, give me a call. I'm around and happy to answer any phone calls at any time, night or day.
All right. And hopefully 2021 is going to turn out better than 2020.
That's right. That's right.
All right, Joel. Thanks a lot.